Hello, I'm Dr. Richard Becker. It's my pleasure to welcome you to the University of Cincinnati College of Medicine's Scholarvision. Today we'll be discussing an emerging topic of importance, that is cardiovascular oncology. I'm joined today by Dr. John Lynn Jeffries from Cincinnati Children's Hospital Medical Center and its Heart Institute. Can you share with our viewers a little bit about the program that you have at Children's and how you follow your patients?
We have a very strong relationship with our Cancer and Blood Disorders Institute at Cincinnati Children's. And with this, we've actually tried to be as proactive as we can be about surveillance for cardiotoxicity. So we've formalized a program that has recognized leadership both from our Cancer and Blood Group and from our Heart Institute that are actively engaged in not only in research efforts, but obviously in the clinical surveillance of these patients. And we've tried to tailor those surveillance programs to the patients and the therapies specifically. So those patients that have received radiation therapy, those patients that have received different types of chemotherapeutics, we would try and employ a very regimented surveillance program for those patients, which may include non-invasive imaging, it may include blood pressure surveillance, it may include imaging of the vasculature, and other non-invasive assessments of early vasculature involvement, such as distensibility, compliance, and we've used advanced imaging techniques such as MR and other modalities in appropriate patient situations. I think the important takeaway is it's not so much always about the type of testing, is that you are being followed and that you do have a plan in place, and that patients should recognize that they are really never out of the woods. The risk factor never completely goes away.
Yes, so you continue to follow them as a part of your survivorship network. Are they aligned with one another?
It's becoming more and more aligned. In children's cancer, the Children's Oncology Group obviously has been very involved in parallel efforts and sort of cohesive approaches to childhood cancer. And I think that more and more cardiac surveillance is becoming a part of the forefront of those discussions. Such great strides have been made in survivorship, and now you have to be thinking about what are the other opportunities to decrease mortality, to increase longevity, to improve quality of life. And much of that is going to be focused on cardiac implications of these therapies.
Yes. You know, in the adult world, there is an emerging literature on preventing some of the cardiotoxic effects, beta blockers, ACE inhibitors, statins. Similar literature in the pediatric population?
You know, unfortunately, there's not as much literature in the pediatric population, but we hope to be driving some of those papers in the near future. You allude to some very important topics in adult cardiovascular medicine. Being an adult cardiologist, we do see a fair number of adults, obviously. And one recent example would be the use of angiotensin receptor blockers as a potential preventive strategy in chemo exposures. I think you have to recognize that there are potential confounders and heterogeneity to these populations, obviously. And we can't forget that there may be underlying comorbidities in our adults. They may have systemic hypertension, they may have pre-existing coronary disease, other things that may predispose them to even more profound phenotypic events related to these exposures. However, that would be fantastic if we could develop a preventive strategy. We are thinking about that in children, as you know. To use drugs as a preventive strategy in a pediatric population, safety always has to be of the utmost focus. And so we are engaged in discussions with other institutions about potentially employing things such as beta blockade, such as angiotensin receptor blockers, as a preventive strategy to follow these patients longitudinally and see if we could mitigate some of the effects of these exposures.
Yes. And for someone that has some of the cardiotoxic effects, treatments?
So typically we would employ conventional therapies, and a lot of that's going to depend obviously on the cardiovascular phenotype. So treating things like systemic hypertension obviously would be important, but also marrying that with surveillance of kidney function and other things that might be exposed as a part of these treatment strategies. Myocardial disease, we would pursue traditional myocardial dysfunction therapies. For those patients with heart failure and with reduced ejection fraction, we would apply guideline-based therapy. I think part of the importance is that many of the patients come back to us with a real question about, I have existing cardiac disease, but my cancer has recurred. I need additional therapies, or now I have a new malignancy that might expose me to other potential cardiotoxic agents. I think that that's a burgeoning area where treatment strategies such as we're talking about are very important to try and mitigate some of the potential outcome in those situations, setting them up to be in as good a position as possible when they're going to get that
Yes.
second, third, fourth exposure
Yes.
to chemo.